All right, welcome. Today we're diving into something super important for any medical trainee, managing heart failure with reduced ejection fraction, or HREF. We're going to take all those dense guidelines and turn them into a clear, straightforward framework you can actually use. So let's frame this up. You've got a patient and their heart just isn't pumping like it should. The big question is, what are the key things we need to do to help them live longer and feel better? That's what this is all about, creating a simple, logical plan you can take right to the bedside. Okay, let's start at the beginning. Okay, first things first, what are we even talking about? You'll see the official definition here, but think of it this way. Heart failure isn't one specific disease. It's more of a syndrome. It's what happens when the heart just can't keep up with what the body needs. This can be a problem with filling up with blood, or, and this is our focus today, a problem with squeezing that blood out. And this is the magic number. LVEF less than or equal to 40%. This is the line in the sand. Once a patient's left ventricular ejection fraction hits this mark, we're officially in the world of HFrEF, heart failure with reduced ejection fraction. You might also hear it called systolic heart failure. It's our absolute key for diagnosis. All right, so before we start throwing medications at the problem, we need a game plan, right? What are we actually trying to accomplish for our patient? Turns out in HFrEF, it really boils down to two big, clear goals that shape everything we do. And here they are. It's super helpful to think of them in two separate buckets. On one side, we have reducing morbidity. That's all about quality of life. We want fewer symptoms, we want our patients to feel better day to day, and we definitely want to keep them out of the hospital. Then on the other side, we have reducing mortality. And that's pretty straightforward. We want to help them live longer. Every single treatment we're about to talk about is aimed at one of these, and the best ones hit both. Okay, so let's start building our management plan from the ground up. You see, great care isn't just about the how, like which pills to prescribe. It starts with the why. We have to figure out what caused the heart failure to begin with. This is why you have to put on your detective hat. You have to ask, what's the root cause here? Is it ischemic heart disease from a previous heart attack? Is there a valve that's not working right? Maybe it's from years of untreated high blood pressure or diabetes. Finding and treating these underlying problems is absolutely fundamental. Seriously, it can completely change the game for the patient. And you know what? This foundation isn't just something we build. The patient is a critical partner here. It's not enough to just see them in the clinic. We absolutely have to empower them with the tools and the knowledge to manage their condition at home. This is totally non-negotiable in modern heart failure care. And this is what that looks like in the real world. This isn't just nice-to-have advice. These are proven interventions. We're talking about things like quitting smoking, for sure, cutting way back on salt, and this is a big one, checking their weight every single day. A sudden jump in weight is the #1 sign they're holding on to fluid. All of this, plus staying up to date on vaccines, it's all part of their self-management toolkit. Okay, so our foundation is solid, we've addressed the root cause and empowered the patient. Now it's time to build the main structure. We're talking about the famous 4 pillars of medical therapy. These are the drug classes that have totally changed the game for HFrEF patients. And this is a really, really important point. This isn't a buffet where you pick one or two. These are the 4 pillars. The goal for almost every single HFrEF patient is to be on all 4 of these medication classes. This is the absolute standard of care today. All right, if you're going to screenshot one slide, this is it. These are the 4 pillars. Let's walk through them. Pillar 1 tackles the renin-angiotensin system with drugs like an ARNI. Pillar 2 is a beta blocker, which basically tells the heart's overactive fight-or-flight system to just chill out. Pillar 3 is an MRA, which blocks a hormone called aldosterone. And Pillar 4, the newest kid on the block, is an SGLT2 inhibitor, which does a bunch of great things for the heart. You put them all together and you get this incredibly powerful combination that saves lives and reduces hospital stays. But what if you do all that, you get the patient on all 4 pillars, and they're still struggling? What's next? Well, that's when we have to move into more advanced interventions. And the approach here is really logical. It's a stepwise process. First, you double and triple check. Are they really optimized on their meds? Are the doses as high as they can tolerate? If the answer is yes, and they're still symptomatic, you move to step 2. You start thinking about device therapy. And if even that isn't enough, that's your cue for step 3. It's time to refer them to an advanced heart failure specialist. So when we talk about devices, what do we mean? Well, there are 2 main players. First, there's the ICD, or implantable cardioverter defibrillator. Think of this as a safety net. Its job is to prevent sudden cardiac death from a dangerous arrhythmia. Then there's CRT, or cardiac resynchronization therapy. This is for specific patients whose EKG shows that the heart's pumping is out of sync. CRT helps get everything pumping together again, making the heart way more efficient. And for those with the most advanced disease, we get into some really specialized territory. We're talking about things like mechanical circulatory support. You'll hear them called LVADs, which are basically pumps that help the heart do its job. We're talking about the potential for a heart transplant. And something that is so important is bringing in palliative care. This isn't about giving up. It's about managing symptoms and making sure the care we're providing lines up with what the patient truly wants. So let's wrap this all up. The big takeaway here is this systematic approach. You start with your goals, help them feel better, help them live longer. You build a strong foundation by treating the root cause and making the patient a partner. Then you put up those 4 crucial pillars of medical therapy. And finally, you know exactly when it's time to call for backup and escalate care. Following this framework is how we make a real difference for our patients. Now, this framework we've just gone over, it's the absolute best we have today. But medicine doesn't stand still, right? The science is always moving forward. So the question I want to leave you with is this. What do you think is coming next? What will be the 5th pillar that changes everything all over again?